death and valve disease. I'm going to focus mostly on mitral valve prolapse, where there is more data. So I want to begin with a case presentation. This is a 55-year-old man who's a farmer who's growing citrons. Citrons in Hebrew is etrogim. So he's a religious guy growing citrons for commercial value. His past medical history is only remarkable for smoking, and he had sudden cardiac death after climbing to his second flight house. He was resuscitated by an EMT team who found VF on the initial monitoring. He came to our hospital, had a normal angiogram. We did a heart biopsy that was essentially normal with no inflammation. PCR for viruses was completely negative. ECG on arrival was normal sinus rhythm, and he fully recovered and he got an ICD. So I'm going, hopefully, yeah, it's working. It didn't work in the morning, and it's not working now either. So I'm going to ask you, who thinks on this echo there is an explanation for the sudden cardiac death? So this is the echo, and maybe there is no voting system, but maybe if, people who think that there is something that explains sudden death on this echo will raise their hands. Like there are about like few people who think that the echo is okay and it does not explain the sudden cardiac death. No one. People who think Bibi will be the next prime minister, maybe, who can. Anyway, so on this echo, I'll show you in a minute, there is bileaflet prolapse. This is Barlow's disease, where you can see the leaflets are thickened. They're both prolapsing above the annular line. And also you'll notice this region here, which I'll refer to in a minute. This is the disjunction between the annulus and the valve. So what's the prevalence of mitral valve prolapse? There is a lot of literature on that. I chose a meta-analysis that was published recently, and if you combine all the population-based cohorts, the prevalence of mitral valve prolapse in the population is 1.2% on average, and the prevalence of mitral valve prolapse amongst people who die suddenly is about 2%. So certainly there is higher rate. There is an association between mitral valve prolapse and sudden cardiac death, and I can tell you that if you look at cohorts of patients that have no other explanation, essentially you don't find the cause for sudden cardiac death, the prevalence of mitral valve prolapse is about 10%. So there is certainly an enrichment for Barlow's or mitral valve prolapse in patients with sudden cardiac death. And so the next question is, if you see a patient with mitral valve prolapse, can you suggest what's going to be the outcome? What's the risk for sudden cardiac death? And so the risk is very low. The overall risk for sudden cardiac death in the cohorts of MVP patients is about 1% in 8 years. So it's a very, very low prevalence of sudden cardiac death. Still, it seems like these patients have a little bit more risk for sudden cardiac death. And there is a lot of literature coming out since this association between mitral valve prolapse and sudden cardiac death, a lot of literature on what's causing it. Several explanations relate to electrophysiology, and there are several features that are unique to this population, which I'm going to show here, if you can see it on the large screen, hopefully. First thing is that there is T-wave inversion on the inferior leads, which is very typical of patients with mitral valve prolapse with increased risk for sudden death. Secondly, these patients have a tendency towards multiple VPBs and short runs of VTs, and these originate either from the papillary muscle. That's why the axis of this VT is north, because it's originating from the inferior wall and moving upwards, or from the, so it either the papillary muscle or the annulus itself of the valve. And there's also, in some patients, you can monitor them and see that they can deteriorate with these VPBs into VT and VF. So there are several electrophysiological characteristics of patients with MVP that may suggest that they are at increased risk. There is baseline ECG changes, increased tendency towards VPBs, which originate from the inferior wall or the papillary muscle, and obviously some of them do deteriorate for degeneration. There are several explanations why this is happening. One explanation, which I particularly like, is the disjunction. So if you look at this valve, which I showed you before, this is the mitral valve. This is where the annulus should be. Okay, and there's disjunction, so the annulus has moved into the atrium, and this is generating what we call redundancy, or increased area of the valve, which generates larger force on which the valve is pulling on the papillary muscle. Because force is the pressure times area. So even if the blood pressure or the systolic pressure is not changing, the area of the valve which changes will cause larger forces on the papillary muscle, which may in turn cause fibrosis or maybe atrial fibrillation. Ectopic beats. This is sometimes what people tend to look at. That is also explaining the muscle pain that we or the chest pain that we sometimes see in patients with MVP, the twitches that they complain of. Some people say that this is because of this pulling of the valve. So this patient, which is religious, we treated him basically because he got his ICD and went home and he's okay, his heart is normal and he's not leaking too much, so he's fine. The next question is, should we do something with the family? Because we know that mitral valve polyps tends to occur in families, particularly myxomatous degeneration. So I don't know how many of you would go on to the family and screen them for mitral valve prolapse. One. Tzaddik Bisdom. How many would two? How many would stop and just treat the patient and let the family forget? One. Out of Pollack, obviously. And how many would vote for Bibi Netanyahu again? I have to just to see that you're awake. So we went ahead and screened the family, and we did that because we're doing research on the genetic of mitral valve prolapse. And you'll see all the ones with filled rectangles are patients with MVP amongst these many kindreds. So they're a very large family. This is why we love to do genetics in Israel, because we get this very powerful for family for genetic analysis. And the question is, what do we do with them? Is there any way for us to suggest that maybe some of them may be at higher risk for mitral for sudden cardiac death? This is just to show you that you can also diagnose mitral valve prolapse with MRI. It's not working, but in our cohort we have currently 53 large pedigrees with mitral valve prolapse, 4 of which were presented with sudden cardiac death. So even in our small hands, we see increased prevalence of sudden cardiac death amongst families with mitral valve prolapse. There is also this association, which was published by Dr. Weissler-Sneer, which I think she trained in Beilinson, right? I don't know her, but she trained at Beilinson, and she did this work during her fellowship in Toronto with Michael Gollum. And they looked at patients with mutation-positive long QT and mutation-negative long QT syndrome. And the patients with mutation-negative long QT syndrome had increased prevalence of structural abnormalities, mostly mitral valve prolapse. So the majority of them had mitral valve prolapse, which is therefore associated not only with VPBs and short runs of VT, but also with long QT syndrome. And if you look at their data, patients, this is the median number of PVCs per 24 hours. You see that patients which are genetic negative have more VPBs. They have and they have tendency towards more sustained VT. So there is an association not just with VPVs, but maybe also with long QT. So who are the patients who are at risk for sudden death who have mitral valve prolapse? You can look at 3 mechanisms. One is fibrosis, if there is increased fibrosis of the ventricle, and you can look for fibrosis with MRI, and this is a little bit tricky, but you want to look for delayed enhancement in the papillary muscle itself. You want to look at the mitral valve morphology, and particularly you want to see bicuspid prolapsing, what we tend to call Barlow's valve, with thickening, myxomatous degeneration, and particularly important is the disjunction, which increases the tendency towards sudden cardiac death. And I think we should start reporting disjunction on every echo report. It's not suffice to say mitral valve prolapse. You need to say how many leaflets and if there is significant disjunction between the annulus and the leaflets. And also there are electrophysiological characteristics that, as I explained, and as I showed you before, T-wave inversion on the inferior leads an increased tendency for VPBs. Even so, these patients would have higher risk for sudden cardiac death. Even so, I don't know of anyone in the world currently who's doing primary prevention for sudden death in mitral valve prolapse. So this is work in progress. We don't know how to address these patients. We do know that there is an association, but we don't know how to treat these patients. So just for completeness sake, I want to also refer to the aortic valve, and I think this has been described before many times. There is an association between severe aortic valve stenosis and sudden cardiac death. This is coming from a Japanese registry looking longitudinally at the rate of sudden cardiac death in patients with severe aortic stenosis, and you'll see that the prevalence of sudden death is quite high. In patients who are asymptomatic, it reaches about 5% over 5 years' times, and those who are symptomatic have even higher rates. And all of us who have a little bit more experience will remember a patient with asymptomatic severe ACE who collapse suddenly. Some of them do get resuscitated, some of them just die. So there is an association with severe aortic stenosis and sudden cardiac death. And particularly when I was working on this presentation, I looked at the recovery trial. Just to remind you, this is a recent publication in the New England comparing intervention versus non-intervention on a small cohort of patients with severe or very severe aortic valve stenosis, showing that intervention, even if the patient has no symptoms, is better than non-intervention. But if you look at the supplementary material and you look at what the patient died of, all these patients who are marked with red died suddenly. Of those, most of them except one were on the conservative treatment arm. So this is suggesting that if you replace the valve, people may die, but they will not die suddenly. But if you don't replace the valve, in patients with severe aortic stenosis, there is an increased tendency towards sudden cardiac death in patients with severe aortic stenosis based on the recovery trial. So if I want to conclude the aortic stenosis data, there is probably an association between sudden cardiac death and severe aortic stenosis, which we are unaware of. Based on the recovery trial and maybe other trials, we may be able to intervene on that, and if we replace the valve, the rate of sudden cardiac death may decrease. However, we still don't know how to act on it. Do we think that in asymptomatic patient with severe AS, the prevention of sudden cardiac death is an indication for aortic valve replacement? I don't know if we know the answer yet for that. And the last topic I wanted to cover is bicuspid aortic valve. Obviously, bicuspid aortic valve may lead to calcific aortic valve and stenosis, so this is similar to any other aortic stenosis, but patients with bicuspid aortic valve also have a tendency towards sudden cardiac death because of dissection. And clinically today, what we're looking at is only the size of the aorta and the size of the aortic growth, and there is a question whether we should do an intervention when the aorta is 50 or 55. This is not solved yet, but clearly we're missing a lot of patients who dissect even though their aorta is not quite at the range of replacement. And so a lot of people are looking into markers that will tell us who are the patients at increased risk. Some people are looking at fluid dynamics. This is what, when I was training, people told me post-stenotic dilatation. I think this is incorrect because the aorta dilates even if you replace the valve. So it's not post-stenotic dilatation, but there are mechanisms trying to explain how the blood flow may influence the dilatation of the aorta, and I think Professor Ronen is working on that in his lab. And there are also other markers. People are looking for genetic markers which will confer increased risk. We're working on genetics in our lab in Jerusalem and trying to see whether a genetic marker will enable us to tell who are the patients with more risk for dissections compared to maybe patients with normal mutation or other types of mutations. And there are several publications, with none of them are excellent, none of them are very good, but there are people who are looking at other markers for for dissections in patients with aortic dilatation related to bicuspid aortic valve. So in conclusion, I want to thank the team that's working with me in Jerusalem on genetics of valve disease. And also I want to remind you that this tradition of valve meetings began when we were able to bring the Leduc Mitral Consortium to Jerusalem, and then we had the first valve summit. This is Michael Golom that I spoke about before. This is Magdi Yacoub. This is Alain Carpentier, and this is obviously Bob Levine, who's been mentoring many of us in cardiac imaging, and thank you very much.